Hi everyone, I want to talk about neonatal pneumonia. Some will be what? Yes, neonatal pneumonia. Let's go. This type of pneumonia is occurring in the first month of life, specifically the neonatal period, which is the first 28 days of life. The timing may be within the first 48 hours of life, or the first week, or the first 4 weeks of life. How 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 did these kill human beings? How did they come across this? Could be through infected amniotic fluid. If the mother was infected and the fetus aspirated the infected amniotic fluid. Could be through placenta transfer, or mother is not infected, but the baby aspirated the content of the birth canal during delivery. Could be during umbilical cord treatment. What are the pathogens here? Group B, streptococci. Remember that I've mentioned it why you do screening in pregnancy, that at gestational age of 36 weeks, the sample will be taken to know if there's group B streptococcus or not. So group B streptococci along the birth canal, E. coli, Listeria monocytogenes, Chlamydia trachomatis, Haemophilus influenza, Staphylococcus aureus, and anaerols, particularly Bacteroides species. Could be viral. There's pneumonia called touch, and they go through the placenta. There's rubella, cytomegalovirus, could be herpes, could be respiratory syncytial virus, and might be others like fungi and mycobacterium or toxoplasmosis. How do we make the diagnosis of neonatal pneumonia? We'll do septic workup because the signs and symptoms of pneumonia is non-specific. So we do septic workup, like we do lumbar puncture and get the CSF for culture, blood sample for culture. If the child is on ventilator, we take trachea aspirate for culture. And if there's pleural effusion, we take the pleural fluid sample for culture. If we are suspecting viral agent, we do polymerase chain reaction test and viral culture. And still on that, we do our radiological investigation here, chest x-ray. What are the clinical features? Fever, when you check the temperature, apnea, ceasing breathing in between, lethargy, very weak, poor sucking reflex. The neonate could be vomiting, come down with respiratory distress syndrome, possibility of abdominal distension, become jaundice, tachycardic, hypotension, or septic shock. The treatment here is admit. You have to admit. And while on admission, first thing is to check the airway, check the orifices, the nasal, the mouth, the ear, for foreign body, for any secretion or bleeding, and attend to that as it is appropriate. We check the breathing system, the chest, any deformity, any excoriations, central cyanosis, peripheral cyanosis, any labor bleeding, we auscultate and count the respiratory rate. But the circulatory system, check the fluid status, the RF fluid up, what's the heart rate say? Any catheter in, any fluid in and out, the amount, we check this and check the entire vital signs. If this child requires mechanical ventilation, we're going to do that without further delay. When we know the O2 sat, we'll determine if to place this child on oxygen or not, but it's most likely going to be on oxygen because of the distress. RV fluid that's appropriate, and of course I'm going to choose the appropriate antibiotics and calculate the dosage based on the weight. Methicillin-resistant Staphylococcus aureus is common, or maybe the pathogen identified, and if that is the case, vancomycin will be good enough. Extended spectrum beta-lactamase, if that is peaked, we give meropenem. And if this is a viral issue, we just treat with supportive management. Psychotherapy, I put psychotherapy here because the parents should be carried along, diagnosis explained to them, and everything we'll be doing so that they can summon courage and follow whatever the outcome could be, but hopefully good. In conclusion, I'm wishing all the sick children well. Kindly subscribe to my channel so that you can get my publications immediately they are released. I appreciate it. Thank you.